When patients see a technologist setting up electrodes, it can look like we're sticking spaghetti on their heads and limbs, but in reality, every single placement has a precise anatomical landmark. Getting it right makes the difference between clean, interpretable signals and noisy, artifact-filled tracings. In this lesson, we'll tour the head, neck, torso, and limbs, focusing on the structures that matter most in polysomnography. Let's start with the head and neck. These landmarks are the foundation for the EEG and EOG. The key landmarks for the EEG, or the 1020 system, include the inion, which is the bony bump at the base of the skull. This is your posterior landmark. The nasion, which is the dip between the forehead and the bridge of the nose. This is your anterior landmark. The preauricular points are small notches just above the ear canals. These are your lateral landmarks. Together, these 4 points define the 1020 grid for EEG placement. Without them, accurate staging would be impossible. The mandible, or the lower jaw, is the anatomical landmark for the chin EMG. The maxilla is the upper jaw. This supports upper teeth and the nasal cavity. The mastoid process behind the ear is used for reference electrodes, including M1 and M2, or alternatively A1 and A2. The masseter and temporalis muscles. These are the jaw's chewing powerhouse. Bruxism shows up here in EMG bursts. The temporomandibular joint, or TMJ, is the jaw hinge, often tied to clenching and bruxism. The tongue is a major player in airway collapse during obstructive apnea. The hard and soft palate include the roof of the mouth and the soft palate, which vibrates during snoring and collapses during an obstructive event. The uvula is the dangling structure, another snore contributor. The adenoids and tonsils. Enlargement in kids is the leading cause of OSA. The esophagus sits behind the trachea, sometimes used for esophageal pressure monitoring, or PES. The cornea in the front of the eye carries a positive charge. The retina on the back of the eye carries a negative charge. Together, these create a neutral charge difference, a dipole called the corneal retinal potential. Placing electrodes near the outer canthi of the eyes, we can capture horizontal and vertical eye movements. Every REM burst you score is powered by a simple charge difference in the eye. The torso gives us the big picture of breathing mechanics. Some of the skeletal structures include the rib cage, which expands and contracts during breathing. The thoracic belts sit here. The sternum is a flat bone where the ribs attach. The intercostal space is the area between the ribs. The ECG is placed between the 6th and 7th intercostal space. The clavicle or collarbone is another anatomical landmark for the ECG. The thorax, or the chest cavity, houses the lungs and heart. Belts here measure thoracic movement. The abdomen. Belts placed here pick up diaphragmatic effort. On the PSG, thoracic and abdominal belts tell us whether an apnea is obstructive in nature, meaning effort is present but no airflow, or central, no effort and no airflow. Finally, let's look at the limbs, specifically where we place EMG electrodes to catch limb movements. The tibia, or the shin bone, is a stable landmark for lead placement. The fibula is the bone located lateral to the side of the lower leg, parallel to the tibia. The anterior tibialis muscle is the star of limb EMG. Electrodes here detect periodic limb movements and restless leg activity. The extensor digitorum muscle helps extend fingers, contributing to limb EMG activity. So let's tie all this together. The EEG relies on the inion, nasion, and preauricular points. The EOG depends on corneal retinal potential, measured at the outer canthi. The chin EMG over the mentalis and masseter track REM, atonia, and bruxism. Leg EMG at the anterior tibialis detects periodic limb movements and restless leg syndrome. Respiratory belts go over the thoracic and abdomen area, giving us clinical data on respiratory effort. The snore and airflow sensors sit over the nose, mouth, and trachea. Each of these rely on anatomy and your ability to locate it precisely. In polysomnography, anatomy isn't just theory, it's practice. Every landmark guides your hand. Every muscle and bone contributes to the signals that we record. By mastering the head, neck, torso, and limbs, you ensure your studies are accurate, reliable, and artifact-free. In our next lesson, we'll move into event recognition and description, starting with the language of the EEG itself. See you there.